Hi everyone, Mariah stopped by here. For my presentation, I was assigned Domain 4 from Patty Benner's From Novice to Expert. Domain 4 is located in Chapter 7, and Domain 4 is the effective management of rapidly changing situations. My objectives are to identify the 3 competencies in the domain, provide professional and personal examples for each competency, explain the importance to nursing and patient care, acknowledge the wide scope of nursing practice, and recognize how being an expert nurse is important for managing these emergencies. So, for effective management of rapidly changing situations, the nurse is the first person to notice the signs of deterioration or change in patient condition. Nurses are the ones that are most available on the floor, both in number and time spent on the unit. So the nurses take care of the emergency until other help arrives, whether it's another nurse, a physician, or someone else on the medical team. And Patty Benner notes that this kind of nursing, taking care of the emergencies alone, isn't often credited to nurses during our scope of practice. So nurses are the first ones to manage the rapidly declining condition as well, and we hope to prevent those emergencies from happening. And even though we have an RRT or a Code Blue team in place, the emergencies may not fall into either categories, and it takes some time for those teams to get to the patient, so the nurse has to manage them until they get there. Patty Benner describes these emergencies as a break in the system. So that means that basically when a patient starts to decline or deteriorate, that's the break. And we want to do everything we can to avoid it, so close monitoring and good patient care. But unfortunately, it's not possible to 100% prevent a decline. Sometimes it happens. And that's why it's an emergency, you don't expect it to happen, but it does, and you have to be able to manage it effectively. So the 3 competencies in this domain are skilled performance in extreme life-threatening emergencies, a rapid grasp of the problem, contingency management, rapid matching of demands and resources in emergency situations, and identifying and managing a patient crisis until physician assistance is available. So for the first competency, skilled performance in extreme life-threatening emergencies, rapid grasp of the problem, a nurse must be able to grasp the problem quickly, intervene appropriately, and prevent further deterioration. Knowledge of the timing and immediate intervention needs. So when did the emergency start? How long has it been? And what needs to be done first? And the ability to assess and mobilize the help available. So for Patty Benner's example, she talks about a nurse working in the emergency room where a lot of the staff was in a trauma bay taking care of a different emergency. A woman arrived by ambulance with complaints of chest pressure, so they assumed that it was a heart attack. She was treated for PVCs by EMS, but when she was placed on tele in the hospital, it showed VFib. So the nurse told EMS to start compressions, and she was ready to defibrillate. But the physician wanted to intubate in case of further decline, but the nurse said no because she knew how long the patient was in VFib for, and she wanted to get them back to a normal rhythm as soon as possible. The patient responded immediately. She was showing good vital signs, and she actually asked to go home for a shower. So she was released the next day, and ultimately ended up being a life-threatening arrhythmia and not a heart attack. So this was the nurse knowing the importance of that immediate intervention of defibrillating rather than intubating. For my personal example, it's not an emergency. I was never involved or really saw an actual emergency, but it could have turned into one if I didn't catch it. I was on a med-surg floor taking care of a patient who had not urinated for over 8 hours. They were supposed to be on a bladder scan protocol, and they weren't scanned for over 12 hours, and they also had fluids running through their IV. So I asked the patient if they had any urge to urinate or if they had in the past and it just wasn't documented. And they said no. So I bladder scanned and it showed greater than 999. So I got my instructor and we straight cathed him and removed about 1,500 milliliters of urine. So if I didn't notice that he hadn't urinated, he could have had further bladder distension and a possible rupture of the bladder, which could have led to an emergency situation. So noticing that it wasn't performed and he hadn't gone could have prevented that from happening. For the second competency, contingency management, rapid matching of demands and resources in emergency situations, the nurse has total awareness of the picture. They know who is working, what all the patients need, and what do I have available to me on the unit. So, like I said, nurses are the most present on the unit. They act as the orchestrator of complex situations, so they keep the unit running smoothly and they make sure that all of their bases are covered for care. We're able to identify key problems and prioritize interventions. We know when to delegate to other personnel and awareness of who is on staff of who can do what. We have confidence in our own ability, seldom panic during emergencies or hectic times. We're able to work in constantly changing environments, which gives us flexibility in care and planning. And expert nurses are able to create a sense of calm during a storm. The Benner example is a nurse in the ED explains how it goes from pretty calm to hectic very quickly, and this occurs over a 2-hour period. Patients came in with chest pain, there was a medical emergency of severe asthma attack, someone had a GI bleed, another patient with chest pain, someone who had insulin shock, a drug overdose, and a febrile seizure infant. So on the unit, they only had 4 nurses on staff, and some of those patients required 2 nurses to take care of them. So the expert nurse moved people to the appropriate rooms, putting some in double rooms when necessary so nurses can take care of both of them. She called the supervisor to come help out. She sent those who needed scans to get the scans so they were taken care of, and she got doctors assessing quickly. So the nurse must be constantly assessing the state of the unit to keep it going steady. The nurse is in charge because doctors don't often know the overall picture of all the patients on the unit. For my personal example, it's more of a what not to do situation. I was shadowing in the emergency room after an interview at a hospital, and a patient came in with seizures and was waiting to be evaluated. They were there for a couple hours. So the patient was incontinent very often. They needed their sheets changed every time it happened because there was a lot of urine coming out. I say my 1 hour I was there shadowing, he was incontinent about 5 times. So we did try an external cath, but it fell off. So every time the tech partner found that the sheets were wet, they would come get the nurse I was shadowing to come help out, which isn't a huge deal as nurses. We are willing to help when we can. But there were other techs that were present on the unit and not busy. They were kind of standing around, just not really doing anything. So the nurse should have delegated changing the sheets to the assistive personnel or tech partner and asked them to ask another tech to help with the sheet changing because he had other patients that needed to be seen. We had to do an NG tube for a patient who had a bowel obstruction, a discharge, IV meds. There was a lot going on, and he didn't need to be helping changing the linens when he could have been doing something else. And then the third competency, identifying and managing a patient crisis until physician assistance is available. The expert nurse has a vast amount of knowledge and skills. They're able to determine what interventions to start and what ones to withhold without jeopardizing the patient's safety. And they have to still stay in bounds of their nursing scope of practice and not do interventions that we're not able or licensed to perform. They have the ability to think outside of the box and come up with uncommon reasons for deterioration that may not be super obvious. The confidence to act without doctor's orders and make their own decisions. And they have a high degree of expertise in their field to identify the emergency and know what to do if the doctor isn't there to provide guidance or give orders. So for Benner's example, a nurse was going into a delivery room with a patient, and they had to use the C-section room because the other delivery rooms were occupied. But this C-section room was not set up for a regular delivery. The mother was pushing and the head was visible. So the nurse yelled to the doctor, "Don't wash your hands, we need you in here now." He didn't listen, so the nurse told her aide to get a pair of gloves and instruments because she was going to deliver the baby. So the nurse delivered and caught the baby and climbed the cord, all while the doctor was still washing his hands. So this was the nurse taking initiative, being able to act when the doctor wasn't present to give that patient the safest and best care possible that she could. And for my personal example, I saw a code blue during my nursing supervisor clinical for my leadership class. The nurses were the first one on the scene, and they started resuscitating right away. The charge nurse assigned specific roles to each nurse that was in the code, who was in charge of compressions, medications, breaths, kind of all that stuff. She assigned it so everyone knew what their role was. And when the doctor arrived, he kind of just stood there in the corner and was giving them orders, what medications to give, when to check for a heartbeat, all of that stuff. But something that I noted was the nurse giving the medications was drawing up the whole vial instead of the half that the doctor was saying. And when it went back to check for documentation-wise, the nurse said I gave 1 milligram instead of a half, and the doctor said that was probably a good call. So nurses may not always listen, but that nurse had previous experience and knew from other codes that this is usually what they do. I'm not exactly sure why they didn't listen, but the patient was resuscitated and they were able to start right away running the code without a physician's assistance there. So the significance to professional nursing: they are able to implement procedures that typically need a physician order, like ordering labs, starting an IV, starting a code. The experienced nurse can oversee the whole picture to prevent errors or the same intervention from being repeated twice. And they can identify the emergency and know what needs to be done. And we work with all disciplines to coordinate who is needed during the emergency. For patient care and safety, the sooner emergency or deterioration is noticed, the more likely a good outcome will be the result. So nurses being present and checking in on patients often is definitely going to prevent an emergency from happening the most that we could. An expert nurse is not waiting 30 minutes or even 5 minutes for a doctor to give orders that may save the patient's life. They're taking the initiative and starting them right away. The knowledge of interventions and care for that emergency means better care for the patient. And nurses being present, caring, knowledgeable, and attentive could mean early recognition and early interventions to prevent further deterioration. So the impact on interdisciplinary teamwork: just like nurses have respect for the doctors must also have mutual respect for nurses. As we saw in the examples, the nurses are the ones who are in charge and handle the emergency when a physician is not available. The physicians also may not view the patient's situation as serious, so the nurse must nudge them politely to give orders, or they will take matters into their own hands if necessary. There's another example of this in the book for Patty Benner, for my domain. And then the nurse must also know what interventions can be delegated to those helping in the emergency and who is best suited for that task. And my reference is the Patty Benner book, From Novice to Expert. Thank you for watching, and I hope you enjoyed my presentation.